Okay, for everybody who's not here, we're going to, let me frame it this way. Look, we're going to finish joints and arthritis. That's what we're doing. So that's the end of the chapter, and we're done. I'm, this is the end of the first 8 weeks. So we're more or less at the halfway point, maybe a skosh ahead of it. The hard stuff's coming Monday. We start muscle and muscle physiology on Monday. It is a big deal. And after that, we get nerve physiology, which is also a big deal. And we get the autonomic nervous system, and that's a big deal. Nothing easy after this. This to me is the basic stuff we've concluded. Once we get into that aspect of things, muscle physiology, the neuromuscular junction, neurochemicals, how nerves and muscles work, how signals are, it's heavy duty stuff. Your full attention is going to be demanded. I can't say it any other way because, and inevitably, the people who show, like on a Friday, the people who show up are the people who I don't have to give this talk to. You know what I mean? So I figure you guys are here because you'd like to be here. For the rest of you who will listen to this afterwards, you should be here. All right. Enough for the sermon of the day, the knee joint. So this is, and look, you saw all the bones in the laboratory. Because there's so many, that was the frame before, there's so much stuff in there. I mean, you have ligaments that are inside the joint, you have ligaments that are outside the joint, you have fibrocartilaginous pads, you have bursal sacs, you have such complexity in this particular structure that it is remarkable how it is. It is certainly the most complex, and it's certainly the largest. Other than that, the base of the big toe, which is called the first metatarsal phalangeal joint, is probably close second, but not terribly. That's why, we were watching last night, Joe Flacco, but Joe Burrow in the Pittsburgh defense, which was horrendous. But I digress. But he ended up with effectively a major surgery for turf toe. I don't think he's coming back for this season. That gives you an idea of the complexity of that joint just by thinking of that particular example, because he dislocated that completely. Nevertheless, this is another complex joint, and this is certainly, by any standard, the most complex joint. It has two. The easy one is the kneecap. It's called femoropatellar. Okay, so all it is, and it's one of those gliding, sliding, plane joints, and it's just a little bit. So when the knee flexes, it moves a little bit. Effectively, the patella acts as a fulcrum that allows you, and it really provides strength. So you can kick out, walk, whatever you think about how that happens. Extend your leg when you're walking or running, generates power in whatever activities you're doing. That's kind of the mechanics behind it. So the exterior of the patella is roughened, it's encased in tendon and ligament, the quadriceps tendon and the patellar ligament. On its interior, it has a cartilaginous portion that glides, hence the gliding and sliding joint. And so it basically moves more or less with the femur. So as the knee extends, the patella comes up, and now it's articulating a little bit more superiorly. And as you bend your knee, it goes down. So it's there. You can get along without one if it's badly fractured. We can extract them. It's not so. I mean, in a serious athlete, that would be a problem. But for you and I, we'd be able to figure a way to get around. And they probably wouldn't do it in you and I unless it was painful. These are the major joints. And again, the fibula does not participate. Do not think for a minute that the fibula is not important. About 1/6 of your weight bearing, and we've done the studies, despite what PowerPoint people might erroneously think, it participates in weight bearing, but you can get along without that, because that's often a bone we use for grafting. Because it's I hate to say non-essential, but again, when you're grafting to take care of an explosive injury or a major deformity, different story entirely. So lateral-medial joints together, tibio-femoral joint, femoral condyles, and the menisci, which effectively are gaskets that are wider on the outside, narrower on the inside. And in so doing, they create a cup-like environment for that relatively flat area on top of the tibia. And in doing so, they again not just facilitate flexion and extension, but allow for the rotational component. So when the knee is flexed, the femur can rotate internally or medially upon the tibia. That's how you would express it. So some rotation when the knee is partially flexed. Very accurate. Voila. Here we are. You have a number of fixed bursal sacs. This gives you an idea of what I was saying vis-a-vis the menisci. Even though you're looking at this from the side, the menisci are wider peripherally, narrower centrally. There are subtle differences between them in their shape. The medial one is a little less circular. The lateral one is a little more circular, but I'm going to highlight the important differences that are there. So here's the complexity. So you have a fairly substantial capsule posteriorly. Anteriorly, you have a relatively flimsy capsule, but unlike the shoulder, there's a tremendous amount of soft tissue. And the name you're going to see very shortly are called retinacula. So the retinacula are expansions, okay, around the tendon and ligament complexes that help to sort of reinforce this flimsy capsule that are there. And so, for instance, when you think about, we're talking about the biceps tendon, what covers that and holds that sheath in place is something called retinacula. It's not quite as strong as a giant ligament, but it's fairly substantial. And when you oversew it, that's kind of the stuff you oversew. Knees are extraordinarily interesting in the fact, I mean, if you want to inject a knee with cortisone or take fluid out of the knee, there's about a dozen places you can find a spot to enter it. So there's a lot of potential passageways. There's fatty pads that are there. There's a bursal sac that's always there. There's another bursal sac that's always there. Names you don't have to know. We're not doing graduate anatomy. All of those things there. Posteriorly, you have bursal sacs. You might encounter in your travels something called, it's on the tip of my head, Baker's cyst. Capital B, and proper name, Baker apostrophe cyst. And it has to do with a proper name rather than someone who's a baker by trade. And it's a cyst that forms, and a cyst is really an enlarged, it's kind of bursitis. And actually, my middle child, my younger son, periodically gets some trouble with that from his knee injuries, from being a stunt biker in the past. So that's back here. So there's a lot that goes on with the knee, and the reality is, depending on where you're going, you're going to see a lot of these. I mean, if you're in athletics, this is something you have to be concerned about. All of it. This is kind of what it looks like. So this is a very famous view. And when I do lab, this is one of the views I have students label, where because it's hard to do that on the bone specimens we have. We have some models that potentially you could do that on. So these are the very, very famous cruciate ligaments. You have anterior and posterior. So effectively, the distinction between them, the collateral ligaments are side to side. The cruciate ligaments are forward and back. And so where you no longer see it on the sideline because we have that magical blue tent in football games. So they take them off, and effectively what they used to do on the sideline, it could be the team trainer, it could be the team physician. With big teams, pro teams, they got team physicians out. With every play, they're getting paid a lot of money to do that. And you would see them come out, and they would have somebody stabilize the thigh, have it in a slightly flexed position, and whoever's doing the evaluation would pull the tibia forward and backward. And it's called drawer sewn. Okay, so an anterior, think of a drawer you have at home, at a dresser, and you're pulling out, all of a sudden it comes out at you. Farther than you. He says the drawer is broken. If it pulls out anteriorly too far, anterior cruciate ligament rupture. Posteriorly too far, posterior. And it can be both of them in a really severe injury. Nowadays, they get an idea in the blue tent, and then they're kind of like, oh boy. And at that point, the MRI is going to be the deciding factor with all of these things with the modern technology. But years ago, that wasn't the way it worked. So why is that so interesting? So the anterior cruciate, as you will see, is adherent not only to the capsule, okay, it's also adherent to the medial meniscus. And as you will see subsequently, The medial collateral ligament is adherent to the same area, to the capsule, the meniscus, and the anterior cruciate. The posterior one, less so. It doesn't adhere either to the lateral meniscus or to the medial meniscus, but you get a sort of a sense, and it's a useful illustration, to see the depth here, the thickness here, thinning out here. Here's the cartilage. So effectively, we've created a certain roundness, like a labrum would either in the acetabulum, or a labrum would occur in the glenoid, for the shoulder or the hip. So that's really interesting when you look at those things. So that's the major degree of complexity. And over here, here's the tibial tuberosity. So the patella is kind of right above it. Very interesting. So the joint capsule, relatively limited anteriorly. The quadriceps tendon. Did you do the muscles of the quadriceps when you were in lab? Rectus femoris, vastus lateralis, medialis, intermedius. They all form into a conjoined tendon called the quadriceps tendon. That envelops and the patella forms within it, and then the patellar ligament is what inserts into the tibial tuberosity. The quadriceps tears occur at the muscle tendinous junction. Why? You're going to learn about this rehabilitative wise. What do we do to strengthen the knee? Straight leg raises. The muscle that's the least represented in the discussion is called the vastus intermedius. You have lateralis, which is huge. We use that to give injections. Vastus medialis, huge. That's why they call them vastus. Rectus femoris, powerful, but that's the big player for extending the knee. And then underneath it is the intermedius. That inserts into the capsule and tenses it. So doing straight leg raises is what strengthens the capsule. And you do what called, we talk about this in muscles, they're called PREs, progressive resistance exercises. You do the same number of repetitions, but you gradually increase the weight. And it's different than your range of motion type exercises. And I mean, I have a fairly extensive background in these types. So I treated a lot of athletes with injuries along this time. Nevertheless, so they flank these are the retinacula. And we do the knee jerk and at least 12 bursa. It's oh Lord, love it, Doc. It's busy. Here you can see the busyness is there. That's the quadriceps. So they all insert. Here you can see the retinacula that comes forward. Here's the ligament, the patellar ligament by the tibial tuberosity. That's about where the knee jerk is. If you're wondering for future endeavors in neurology, that basically you're testing L2, L3, and L4 nerves. You do all the nerves coming out of the spine? Yeah, L2, L3, and L4. It's not like one. Pardon me? You didn't do those. Okay, you did cranial. You didn't do the peripheral nerves. Sorry. I'll leave a note. Whoever's going to do AP2, because it's not going to be me. That's right. You won't have me to kick around anymore. See, look at the fibular or lateral collateral ligament. It's away, where the tibial or medial is not. That's what meant by extracapsular and capsular, and obviously the cruciates, crisscross, intracapsular. So, capsular and extra, fibular and tibial collateral ligament prevent rotation when the knee is extended. I'll buy that. In the back, the back is a lot stronger. You don't have to worry about oblique and arcuate popliteal ligaments. That's a very complex area. Anywhere you get these neat things, the axilla, the cubital fossa, which is for your elbow, popliteal fossa, all very busy area. Blood vessels, nerves, muscles, tendons, big time busy. Okay, so there's a lot of anatomy there that no one would hold you to at this level. I mean, this is just give you an idea. It's just busy. So here they are. This is the anterior and posterior, forward and back, hence the drawer sign. Antithesis, so the anterior cruciate, anterior tibia, prevents sliding of tibia and stops hyperextension. Blah, blah, prevents backward sliding and forward sliding, blah. But effectively, what I told you. You just have to know where they are. You don't have to know their excursion per se, but understand the anterior is the one that's more interesting in the sense because of its adherence to the medial meniscus, plural is menisci. And voila, very good. We actually see this. Before we were strictly doing arthroscopic knee surgeries. This is the view we had. We had a straight scope in the earliest days. First one of these did was 48 years ago. And we'd look in the scope and you could see what they see today, but it was really just to see if there was what kind of, and then we had to basically take out the scope and open it up. And you would actually see this view. You would see the ligaments. You would see that you almost make a slight cut like that and flap it open. So here the anterior cruciate, and even though it's not a great, but it is adherent to there, and the posterior. So the posterior is wider posteriorly, and the anterior is wider anteriorly, as the name would suggest. And then we wouldn't cut this. We would just retract it, pull it out of the line of fire. And you see the beautiful cartilage and everything like that. I mean, it's complex. It's in there. And here they are. This is obviously a dissected specimen. So you can see the gaskets. And this guy here, and this guy's here. Notice, pretty far away. Notice, pretty close. Distinction. So this is nothing new under the sun. The first author in sports medicine, when it really became the science, was back in the late 50s, and I think it was at Oklahoma State. It was, football or Oklahoma, which, if you don't know your NCAA history, had a couple of undefeated seasons in a row. A very famous coach named Bud Wilkinson. I didn't have a lot to do with the kids when I was a kid. I just, old records. Knee absorbs a great amount of vertical force, however, is vulnerable to horizontal injuries, particularly when the knee is fixed. Non-contact injuries with a twisting moment typically just rupture the ACL if it's going to be a serious injury. These you get the three, and he described these, the triad of injury: collateral ligaments, cruciate ligaments, and meniscus. So a lateral blow to the knee, particularly when the leg is extended and coming from the outside, blows out the inside. So just the ACL, runners who change direction. So we saw one of those, and because on Sunday, because the field was such a mess, I don't know if they are attributing it, because I'm trying to go back and look to see if Miles Killebrew, if it was on bad turf or not. I didn't see it as being bad turf. Everybody's going to complain about it. And surgery night. And here you can see it. So here you can see the tear. Tibial collateral ligament, medial meniscus, anterior cruciate ligament. And here they're just showing as a hockey injury. Just for example, I don't know how common it is in hockey. That's the knee. So remember that. That's something that really, it's going to come around. I think I have not done the joint portion of the test, so I can't tell you what's on there. But despite the fact that I'm not in an overly happy mood, okay, but it's all right. It was a good game, and I will do those dictations this weekend. So on Sunday, be rooting for Manchester United over Liverpool. I will retain my mood there. Okay, common injuries for all. I have one of these. I got it from bending. I got it from moving my kids' car seats when they were little in and out of our Blazer, an old style Blazer. And then I had it, and then I got it it actually tore when I was picking up toys at our local Y in the kids' playroom when the boys were like 2.5 and 1 year. Ah! So compression and shear stress, and this is what happens. The worrisome is it will tear, and it potentially could be a problem. The cartilage is not going to repair itself. It heals with scar cartilage. The problem is if you don't do something about it, little pieces of that cartilage are going to shear off. Basically, from being destroyed, they're going to turn into calcified cartilage, almost like bone, and get stuck in the joint. And then the joint locks up. That's exactly what the local orthopedic surgeon told me. He said, it doesn't hurt so bad, now I can move it. And he goes, the worst thing that's going to happen, and all of a sudden it's going to go whack, and you're going to be in big trouble. So I had that repaired. Arthroscopic surgery, basically what they do, they don't remove it per se, they shave it down. you basically take a fine drill and sort of just burr it, like a fine burr, like your dentist would do to smooth something out. And basically, in an arthroscope, you have fluid coming in, you have a probe where you insert whatever you're working with, you're doing it under direct visualization, and you have, sucking out the fluid pouring in, fluid going out continuously. That's how that works. Okay. And theoretically, the healing's a little bit better. I was probably back to work in about 2 or 3 days with that. But I was seated for work most of the time. My leg was straight. So removal renders the joint less stable but mobile. Okay, and then you don't want to completely remove it. Now there's more advances today. Okay, and these are types of things. There's injections that you might have heard about with people with knee injuries, something called platelet enriched plasma, or PEP. And not that you have to know, this is more contextual. There's something cool that you learn about called platelet derived growth factor. I talk about that in AP2 when I do it. And side note, if you're in AP2, I don't know who's talking to you. You have something, you have a question, I'm going to be here this spring, despite them trying to entice me to retire. They offered a retirement package for those of us who qualified. Oh boy, did I qualify. But I'll be here. Who else would I have to annoy? So I can't pull this nonsense. I was going to use another word. She would probably tell me to. How should I phrase it? Shut the front door. So this is what it looks like. That's the tear. You see, nice and smooth. When you get an irregularity, you burr this away. This is looking at directly on via, and this is what you get. You get these if you do arthroscopic surgery. And if you have it on you or somebody you know, they'll give you the pictures. They do it all the time. It's easy these days, digital print. Sprains v strains. A sprain, okay, is actual damage. A strain is the force. The terms are not interchangeable. So when you strain something, that's the forces acting upon it. The sprain is the actual damage. Typically, we grade them first, second, and third. Okay, however you want to. Have you got first degree, mild, moderate, severe. First degree and second degrees typically are treated conservatively. So the first degree is, think of it this way, is stretching and maybe microscopic damage. Okay, second, you have more extensive damage. Third is when you start to be able to get actual damage, when something has torn and you can identify that it's torn. That'd be the way to describe it. So, and typically, if you take a typical ankle sprain or knee sprain, you'll know if it's third degree because it's just not going to get better very soon. And that's something that's done by assessment. That's not my job here. So partial tears repair very slowly because of poor vascularization. Very true. So that's why sometimes the need for surgical intervention. So this is, these days, because they don't heal well, they heal with scar tissue. And basically the way that you have to approach these things, if indeed somebody is what we would call a high output or a high level athlete, a serious amateur, professional athlete, collegiate athlete, somebody who's just a recreational athlete but a fairly high level. At that point, most of the time you're looking at grafting, because it's better to replace these things. And we have, in modern technology, they're going to come up with things that are going to be more physiologically compatible with some of the biomaterials we have today. Okay, so there's a lot of changes, and I don't want to speak any more about that. Okay, but first and second degree type injuries where there's not an obvious visible tear and they can assess that, typically with MRI, most likely the approach will be conservative. Again, my middle son had one recently from a job-related problem 4 years ago, and he was seeing the knee guy at the group. That's the Steelers and the Penguins. It's their team doctors over in Aspenwood, St. Margaret's, and their knee guy. Interesting, a young guy originally from Clarion, and then went to medical school here in Pitt. Looking, goes, yeah, it's borderline. I said, but I wouldn't operate on it. Nobody, doesn't need it. So the difference, the terms are there. Dislocation, okay, they're partial and complete. Partial is subluxation. Dislocation, a la the turf toe that Joe Burrow had, would be a complete or a luxation. And all of these things, and then there's just, not only do you have to reduce them, in certain instances, you have to do something to restabilize them or reattach those structures, or however you're going to go about doing it. That is the end of the joint part, with the exception of the rest of the program on arthritis. Now, you can see I drew a bell curve up there. I'll get to it. Arthritis is what I fondly call a garbage term, inflammation of the joints. It doesn't mean that there's going to be joint destruction. It doesn't give you a reason why it occurs. It has some things that are consistently associated with it. So itis means inflammation of something. So is it a bursa, bursitis? Tendon, it's not the tendon, it's the tendon sheath. Okay? Because the tendon's a rope, it doesn't get inflamed. That sheath, wherever it is located, whatever kind of synovial enclosure, that's what becomes inflamed. So there's better ways to name that than tendonitis, but for the sake here, unless you go into field, we have to be very precise. There's periostitis from inflamed periosteum. There's capsulitis from an inflamed capsule. But people say, "Oh, I got my arthritis is kicking up." That's fine. We're not asking you to make a diagnosis for a chart or for billing purposes that are there, but to understand the different kinds of arthritis. And yeah, the golden rule: if you sprain your ankle, and you say, I don't think it's that bad. You're going to learn the acronym if you don't know it already. People talk about PRICE, pain, something for pain, typically anti-inflammatories. Be careful. You're taking ibuprofen or Aleve, very easy, over-the-counter medications, aspirin. Those are all anti-inflammatories. They all cause damage to the gastrointestinal tract lining. You must take them with food or milk, period, in a sense, forever. 70% of the people who take these on a continuous or relatively frequent basis end up with damage to the gastrointestinal lining. Hello? 2 giant ulcer surgeries. Thank you very much. Thankfully, no problems with that for the last, 25 years. It has something to do with my divorce. That was humorous. I wouldn't have married me. My first wife's a wonderful person. I mentioned RN, BSN, smart cookie. So on with the show about arthritis. So pain, rest, ice, initially, first 24 to 48 hours, ice, not heat. Heat increases swelling. Elevation, compression. And if you're using compression, you'll see it. You're going to see it clinically. And if you see it, believe me, if they show you how to do it in nursing and it's something, and they start doing that figure of 8 thing around the ankle, do not say to them, Dr. Stein said you should never do that. But you should never do that. When you use an ACE bandage, it's one of the biggest weapons that ever existed. You wrap it like a tube, gradually increasing the compression as you start heavier compression distally, and as you bring it up proximally, okay, then you begin to reduce the degree of compression. That's about gravity. That figure of 8 thing, don't know what you're doing. I mean, if you see it on a sideline in a professional game, they're paying those guys millions of dollars. They can do what they want. Different. Their goal is to get them back in the game now. So understand all this stuff. There's different ways to look at this. I do this lecture all the time, and it's absolutely true. On with the show. We talk about arthritis, and by definition, it's inflammatory. It is not, but the difference between inflammatory or degenerative diseases is significant. A true inflammatory arthritis, the culprit is your immune system. Most of the time, it's your body attacking itself. Whether it came from an infection, whether it came from something hereditary, whether it came from something that you were exposed to, doesn't matter. Okay? Some miscoding in your body, doesn't matter. Okay? That's a true The culprit that's causing the damage is your immune system. When it is caused by far and away the most common, or something you should see shortly called osteoarthritis, wear and tear over time. Don't worry about everybody. Most likely you're going to get it. It's just coming your way. We all have it. My back is a mess this morning. I was lifting stuff I shouldn't have lifted without help yesterday, but seeing the chiropractor this afternoon. Hundreds of different types of inflammatory degenerative diseases that damage joints. Most widespread crippling diseases, all true. When I say pain, stiffness, swelling, all true. They all have, globally speaking, very, very similar manifestations. But there's lots of different types. The osteoarthritis, the most common type. That's wear and tear. Most of the time when you hear somebody, my arthritis is killing me, like I'm talking about, that's what it's from. Could it be underlying osteoporosis? Sure. But again, this is something, for you folks in sport, this is something that might come back to bite you 25 years from now. Just be aware of it. Is that a reason why athletes are retiring early? For sure. That and, CTE and related problems associated with that. Rheumatoid arthritis is sort of the poster child for true inflammatory arthritis. It is by definition an autoimmune disease. You get a lot about autoimmune diseases, or you should, when you do immunology in AP2. Again, I'm happy to help you with that if you have questions. And then we're going to also look at gout. Gout has to do is basically a metabolic disease because you are unable to dispose of efficiently a chemical that you have to produce. It's a metabolic waste product called uric acid. I'll get to that when we get to that portion of the slide. We all have a certain amount that we're allowed to have in our bloodstream. If we have too much, it creates problems. So, osteoarthritis, degenerative joint disease, doesn't matter. Do I get hot and inflamed? Is it painful? Sure. Okay? But again, it's all about the wear and tear. Big word. Irreversible. Progressive. Just gets worse over time. Does not mean it's not treatable. And these are the folks that you have to be cautious with anti-inflammatories long term. Nearly all the medicines they've ever tried for this thing just tear a hole in your stomach. That's always the wonder drug. And every time they get one of those wonder drugs, they're not tearing a hole in your stomach, they're impacting something else. Yeah. Could it be enzymes? Sure. Cartilage broken down, faster to replace, I'll buy that. Okay? And this is what happens. Cartilage begins to, as it deteriorates, it effectively forms little form osteophytes. So really calcified cartilage is transitioning into bone and gets stuck in those neat little pleats that I was telling you about in the joint. And despite I am not 85 yet, I've got another 10 plus years. I'm sure if you come back in 10 plus years to visit, I'll be right here. I'll be around for 25 years. Yes, something. So, what does it look like? This is a big difference. You take a normal looking joint like this. First step that we see with this, it begins to narrow. So we begin to see squaring off to the joint and narrowing. Osteoarthritis narrows, squares off, and most of the time initially, bone, or the density of the bone, meaning the degree of calcification, increases. Narrows, squares off, bone density increases. And eventually over time, you almost see something that looks little if you draw it down like this. If anything, the other thing it begins to do is if you start to see the joint actually widens. So that's what people are heading to. So what do you do about it? Eat. This is when it's not on a regular basis. Heat and exercise have been the golden rule forever. They still are. There's topical agents you can use. They still work. Okay. There's a lot of things that work for some people, don't work for everybody. We're getting there. Normal aging process. Sounds, when you move the joint, you can either feel it almost, and you almost sense, and sometimes you hear a sound. Fancy name is crepitus, but they use that in other things. Moderate activities, mild pain relievers, capsaicin. You know what capsaicin creams are? Even over the counter now, when they were prescription, when I first started prescribing, they're made from an extract of hot red peppers. You did not culinary. Peppers are in the category: green peppers, red peppers, cayenne peppers, ghost peppers, habanero peppers. They're what are called. They're in the category of capsicums. The heat from those peppers that are very hot comes from the seeds and the membranes that are inside when you open it up. So if you're cooking, you cut those out and just use the flesh. It depletes something that we're going to hear about down the road when we talk about neurotransmitters about pain, called substance P. And that we think that's a mediator of pain. We don't even have an identification for it. That's how they work scientifically. In my hands, and I've used it early on, I use it a lot for diabetics, it's 1/3 rule. Third of the time it helps, third of the time it doesn't do anything, a third of the time it irritates the skin and makes it feel like it's burning up. So only about a third of the people it helps, but it does help. Okay. I call bullshit. 20 years ago, I couldn't shake hands with somebody. Cosamin and chondroitin sulfates helped me. There's a reason they put it in dog food. We just put a giant bag, which would hurt my back, for the pooch over at Costco yesterday. And what's in that for healthy formula weight control? Glucosamine and chondroitin sulfate. It helps a lot of people. It is a building block for connective tissue, particularly so in cartilage. So so interestingly enough, it's like anything else. If you put more of it in there, it's more ingredients. Theoretically, can make more cartilage. It doesn't help everybody. It helps some. And yes, some nutritional supplements are effective. Okay, doofus. But really, heat, rest, exercise. That's what. Moving on. Different. What's different about this autoimmune diseases? So the first step in these, widening of the joint due to swelling, bone density decreases. You see it almost looks more osteoporotic. The joint itself, after widening and swelling, typically becomes unstable. It begins to a certain extent, increases the tendency toward dislocation. And yes, there's other kinds, and it's a different kind of arthritic disease. So they both end up very similar in the sense that you can tell they're arthritic, and they start different. Okay? Because the inflammatory process causes the joint to fall apart. The poster child for this, autoimmune diseases, rheumatoid arthritis, other ones that you'll learn about: systemic lupus erythematosus, psoriatic arthritis, just to name a few. Men get something called ankylosing spondylitis. I technically have a diagnosis of an immunological arthritis. It probably was a reaction to immunotherapy that they were using to treat my bladder cancer. Thankfully, and I don't take the medicines that they use anymore. That's a whole other lecture. That's something I talk about a lot. Physiology of the immune system. Beware. Remember osteoporosis, more likely in women? Guess what? 75 to 85% of people who get these disorders, there's some that, for instance, ankylosing spondylitis, something we see more often in men. But rheumatoid arthritis, lupus, women. My clinical career, probably about 80 to 85%. Statistically, they're going to tell you about 3 out of 4, but in my end, it was a little bit higher. And this number, maybe it manifests itself dramatically then. The most common area, a range you have to be concerned with, and hello everybody here, 15 through 55. We call that second through fifth decade. So you start seeing information about that now. Okay, what may occur at any age affects 3 times as many women as men. I'll buy that. Joint swelling. So with this, typically unilateral and large joints, shoulders, knees, elbows, etc. Big joints. They're their ankles, if you will. Rheumatoid, but on the other hand, the two inflammatory ones, small joints, hands and feet, and very famously, bilateral and symmetrical, meaning it's the same on both sides. Very important word if you're going into a clinical career. Bilateral and symmetrical. We always look for symmetry. It's the same on both sides. Is it different? When it's different, trauma. Everybody able to read that? My bad handwriting, that's why I'm enunciating it. Other things, because it's systemic disease. Typically comes with a certain amount of anemia, osteoporosis because the bone loses its density, other problems associated. It's a global disorder. You wouldn't wish it on. Hence the curve. Remember I asked about activities of daily living? Wednesday, ringing a bell, right? You say that? Okay. Bell curve. Here's the median and then one. You're all familiar with this. This is what we call these standard deviations. So on a true bell curve, within one standard deviation, you would find 40% on either side, 10% in a second standard deviation. Think of this as severity. Y-axis. Yeah, think of it this way. Good side and bad side. Bad side, good side. What does it mean? 10% of the people who have a diagnosis, say rheumatoid arthritis or lupus, have the diagnosis. It doesn't affect them whatsoever. But they have the diagnostic criteria. The fact you have a diagnosis doesn't mean it's going to change your life. But you meet the criteria for the diagnosis. So 10% of the people. 40% of the people have that diagnosis. Affects them, okay, to an extent they can still function. Kind of like what I have. And really doesn't limit, maybe that takes a medication, don't. And in a matter of degree of what they have, but they can still basically do everything. They can work, get around, they don't have major league problems. This is the bad side. This 40% means it affects their ADLs, activities of daily living. Now, you have something very serious. They can't do everything for themselves. And this last 10%, real bad. That's the ones that, suffice it to say, we saw a case and on rheumatology rounds at a rehab center up in Philadelphia. I was a student, and this poor individual was a girl in her, he said 20s, who 6 months earlier been perfectly normal. And when it was the most shocking thing I can remember. We went into the room. Normally you go up and you'd be examining patients and the doctor would be explaining it. He goes, stay back here. Just look inside the room. I'll go up to the front. And all you saw was this in a fetal position. Clearly a woman couldn't have weighed more than 85 pounds, just making those mewling sounds. You would touch her like that. And he asked a few questions, walked away. He said, we'll talk about it outside. We went to another room. He goes, would you believe that 6 months ago she was as normal as you? Rheumatoid arthritis. That's the 10%. I'm not making this stuff up. Don't have to. Just to give you an idea of what these things are like. So they're distinctly different, and there's many sort of flavors in that sort of melange. Synovitis is the affected joint. Blood cells migrate, release inflammatory chemicals. Okay, so effectively, it starts to swell. So those inflammatory cells attack the joint. Fancy name for this thing that is sort of debris, white blood cell debris called pannus, clings to the cartilage. And what happens over time? Eventually, the joints don't move. Ankylosis means the joints can't move anymore from all the scar tissue. And then lots of things for all of these, same thing, steroidal, non-steroidal anti-inflammatory drugs. We have a lot of biological agents. I'll finish out a little nugget of this down the road and make sure you get it, because I didn't quite get to what I thought I would. So immune suppressants slow it. This is what I was taking. I was taking something called Humira, which you see advertised all the time. That attacks tumor necrosis factor. And again, all of these you can treat surgically, potentially, with joint replacement. Classically, you see this kind of, it's called fibular or ulnar drift. The fingers kind of that way, it dislocate large mounds, and that's the visible thing. It happens in hands and feet. And this, rather than me give it short shift, I'll make a mental note to make sure I get this little nugget for gout, and interestingly enough, for Lyme disease when we come back on Monday. Thank you. Have a really good weekend. Nice talking.